So good evening, and needless to say, I'm privileged and honored to be here. And thank you, Arshad. Most of the time it happens that people say that it doesn't need introduction and then embark on a good 10 lines of introduction. So I was little worried. More worried because of Yash's inclisiran example, because I'm going to talk on inclisiran a little bit. Okay, so lipid management is oft visited. In last 30 years, I think number of talks each of us has given or listened to on lipid management probably would be in more than hundreds, or probably literally amounting to 1,000. Still, we keep on visiting lipids. One of the reasons is, it reminds me of a very often told joke, very old joke, about a certain person who was in the dark of the evening was searching something very frantically just below the street lamp, and somebody came and joined him and started looking for it, whatever was lost. And he asked him, what is it? And he said, it's the ring. Third person joined, fourth person joined, and after a while nothing was found, and they asked him, sir, where exactly you dropped it? And then he showed some 20 feet away a dark spot, and they said, why you are not looking there? He said, no, because light is here. So many times we thought that we are treating LDL because we can treat LDL, and we can treat hardly anything else. And that is the reason why we treat LDL. That's the reason why we treat cholesterol, because that's most easily treatable. We can reduce cholesterol, LDL, from 160 to 40, 30 nowadays, and that gives us a kick. What we can do, we cannot do that with blood pressure, we cannot do that with diabetes. The patient will die, in fact. And here patient doesn't die. And we seem to discover that not only the patient doesn't die, maybe he's getting better. And that's why so much of interest in lipids. Another example that I remember is an article by W.C. Roberts, written in 2001, and I attended his talk also, was fortunate to attend that talk. And he argued very persuasively, in 2001, mind you, that cholesterol is the single most important predictor of atherosclerosis. And he argued that there is no hypertension, no LVH, and still person can get atherosclerosis and an event. There is no diabetes, sugar levels are absolutely normal, still a person can get heart attack, and it will be difficult to treat by lowering sugar or by lowering his blood pressure. But no matter what the cause is of heart attack, you bring LDL down, you bring cholesterol down, and that person benefits. That is true. Even a smoker or a tobacco chewer doesn't benefit as much by stopping the smoking as the benefit is seen by treating the cholesterol. And that's probably the reason why we talk about the cholesterol. Cardiovascular disease is leading cause of death worldwide. Still true. This kind of something like this I have shown for nearly 25 years, more than that, in every talk about cardiovascular prevention or disease or cholesterol or whatever, no matter what cardiac talk you give. This is there since last 30 years, barring accidents and barring infections in some poor countries. India used to be one of them. Cardiovascular disease is the #1 cause of death everywhere. there is only one state in US which has overtaken, where cancer has overtaken CV death as number one cause of death, all types of cancers combined, mind you. But other than that, not a single country where this is not a leading cause of death. The disease burden in India, again, these kind of slides used to give the shock and awe type of effect. It doesn't anymore. Indians have higher ASCVD risk. They develop it at earlier age. They exhibit more severe form. They have higher mortality. They have poorer outcomes when treated. All this we know very well. This study, yes, it did to some extent shock and awe us. ICMR INDAB study, which came out in 23 in Lancet, one of the most meticulously done study to come out from India. And it showed that the prevalence of CV risk factors was so high, very unlike what we used to think. And even for people who are in the field, for them, this was really eye-opening. I'll talk a little about LP(a), non-HDL and LDL-C clubbed together as risk factors. These are all atherogenic lipoproteins, and these all molecules or these all particles carry ApoB molecule. So all ApoB containing lipoproteins are associated with increased risk of atherosclerosis. This is something what we have understood. Lot of evidence on this. I'll not be able to show you all the references because there are so many. The overall atherogenicity of cholesterol is probably due to apolipoprotein B. All the particles which carry this molecule have atherogenicity of various degree. In general, we have talked a lot about LDL cholesterol versus non-HDL cholesterol versus small density LDL versus ApoB. Which one is more accurate predictor of CV outcomes? Which one is more accurate predictor of atherosclerosis? In general, all correlate very well with each other, no matter what you really measure. And LDL-C is now most accurately and consistently, almost everywhere, every lab now measures LDL-C very well. So that incongruity is much less nowadays. So LDL-C still holds sway. Non-HDL-C could be probably more accurate in predicting the risk, but more or less LDL is the measurement which you find very easily and very relatively inexpensive. How atherosclerosis develops, this or some kind of this busy slide, everyone has seen how LDL-C particle goes into the vessel wall, how it goes into the cell membrane, how macrophages approach it, how the foam cells are formed, how a fatty streak is formed, and then how oxidization takes place and how later on calcification takes place as the plaque stabilizes, and how plaque ruptures and how it gives rise to events. All these things are very well known, and I don't think we need evidence. We need to spell out the evidence for that. So if you look at LDL cholesterol or non-HDL cholesterol, we know that all lipid lowering therapies basically act by lowering the LDL, by increasing the hepatic uptake of LDL-C, and thereby increasing the clearance of LDL, and they achieve the target. No therapy not affecting LDL, affecting only triglycerides or affecting HDL only, has been shown to improve cardiovascular outcome. So lipids are very important. LDL is the central driver of atherosclerosis and probably to some extent events also. Of course, there are many precipitating factors, like undue, unaccustomed physical exercise, or a very single large fatty meal, or partying, holiday heart syndrome, and lots of other things. These are all precipitating factors for plaque rupture. But the plaque formation, progression, and even to some extent the plaque rupture is driven by LDL-C. A little bit about LP-little-a. A long back, Inas A. Inas wrote about high prevalence of increased LP-little-a concentrations in expat Indians, South Asians, in fact, Southeast Asians. And then we have learnt a lot very slowly over a period of 30 years about LP-little-a. We believe that LP-little-a is genetically determined. We believe that LP-little-a is very important risk factor for atherosclerosis and events. We know that LP-little-a is very important risk factor for development of aortic stenosis. We know that in presence of LP-little-a, effect of all other risk factors gets magnified. So if a diabetic has high LP-LA, the effect of diabetes on his CV risk increases. Same thing goes for a smoker, same thing goes for hypertensive, same thing goes for any other risk factors that have been studied. All major risk factors are potentiated in presence of high LP-little-a. What we don't know about LP-little-a is that treating LP-little-a, bringing it down, does it improve the CV outcome? We do not know. There have been drugs which have incidentally lowered LP-little-a while lowering the LDL, and they have shown benefit, but that doesn't prove that that benefit comes from lowering LP-little-a. So in presence of high LP-little-a, the only recommendation we have now, right now, is that treat all other risk factors more aggressively. We also know, because of this, that LP-little-a determination or measurement is important only once in lifetime. Right now. That's what we believe. Because measuring it again and again, showing its fluctuations, it has decreased and it has increased, that increases the anxiety, nothing else. Doesn't have any other indication or benefit. If you talk about relative heterogeneity of LP-little-a and LDL, LP-little-a particles are very small. Overall, very less concentration, but if you take particle to particle, heterogeneity is supposedly 5 times that of LDL particle. Again, not a very clinically relevant information. All said and done, amongst the topmost risk factors for atherosclerosis and for cardiovascular events or MACE is LDL-C. Another thing which we have learned over these 30 years is that the LDL cholesterol, LDL-C magnitude and duration of exposure determines the risk. If you check somebody whose LDL-C is at 140, another guy whose LDL-C is at 160, you automatically assign more risk to the 160 LDL fellow, saying that all the other risk factors are same. But that is not always the case. Many times you see that the person with 140 or 120 LDL got the heart attack first. If LDL-C is the central driver, why does this happen? Because you do not know what was the LDL-C exposure of that particular person over so many years of life. That has never been, measured for cholesterol levels. So LDL-C exposure to the vascular tree determines not only the magnitude. When you check the magnitude, it's a snapshot. It is, as I always say, that I would always like to say, like one of my teachers used to say, that all these snapshot tests are like taking a picture, like a snapshot. Someone is smiling, that doesn't mean that he is always smiling. And someone is crying, that doesn't mean he is always crying. You are trying to determine that this person is smiling, so he will be smiling 10 years later. Not going to happen. So LDL cholesterol magnitude and duration of exposure, this is seen in now many, this has been confirmed by many meta-analysis, and cumulative LDL-C exposure, and we'll come to that, some interesting facts later on. And that has changed our LDL-C goals in last 15 years. Last 15 years, we were talking about LDL-C less than 100, then we were talking about LDL-C less than 90 in Indians, 10 less than Western counterparts. Then we talked about LDL-C less than 70 to treat the atherosclerosis, to get the secondary prevention. And now we are talking about 40. Another thing that has come up recently is early lowering. Once you get ACS, LDL should be lowered as early as possible. Why? Because the first 90 days after ACS is a critical period, and this is where there is acute increase in the recurrence. So 1 in 10 patients reported a second MI or a stroke or a CV death within the first 3 months of experiencing an MI. So death, MI, or any recurrence of MACE is elevated in first 3 months after the ACS, and that's why it is very important to reduce LDL as early as possible. Does it benefit? Yes, there is evidence that it does benefit if you lower the LDL very fast, start from the first day, and if you reach your LDL goal within first month, it gives you more benefit. And if you reach your LDL goal in first 7 days, it gives you even more benefits. And there are a number of trials suggesting that. And how early is early? As early as possible. Another question is how long we keep the LDL lowered. Today I had a patient who said that I have done 3 injections of evolocumab course. Then I checked my LDL, it was 58. So my doctor said, do 3 more, 1 more course. I had hard time explaining to him that it is not a course. This LDL you are going to require for lifetime. And sustained lowering is important. That has been shown by so many trials. Long-term lowering of LDL-C lowers the risk of events long-term basis. So all these studies, if you make a meta-analysis, that long-term exposure to lower LDL-C level is associated with lower risk of MACE compared to short-term exposure to lower LDL-C. So longer you keep the LDL-C at target or at goal, better it is for the patients. If you look at the Sweetheart study, interesting scenarios. One group where you don't reach the target LDL at any given point, studied for 1 year. Second, you reach the target at 2 months, but are not able to sustain it for 1 year. Scenario 3, you don't reach the target at 2 months, but you reach at the end of 1 year. And scenario 4, you reach the target at 2 months and then sustain it for a period of 1 year. And I don't think that you need to look at the results of the registry, which scenario is best. So I'll just skip it. You get additional benefits of lowering it early and sustaining it longer over a period of 1 year. What if you sustain this target for 12 years? So you have meta-analysis for that also. If you sustain this target for 12 years, lower and longer is better. And you can see that from this particular table, which was there in this article of European Heart Journal. So lower, sooner and longer, that is where we are looking at about as far as LDL level is concerned. There are challenges to achieve this kind of reduction, because every time we talk about this, somebody will get up and say that it's not possible. My patients do not get to LDL 40 without side effects. And we have to reduce the dose of statin, or we have to do this and we have to do that. Cost is also an issue, of course. And medication burden, patient compliance is a major challenge. And apart from compliance or apart from adherence to the therapy, there is LDL-C variability, which we have seen recently, that somebody gets to LDL 30, 20 very fast, and then as you try to sustain that level with the same therapy, the LDL levels creep up back to 50, 60, 70, 80 sometimes. Then you do something else and then again they go down. This kind of variability has again adverse impact on the MACE. So lowering the heart disease risk with reduced lipid variability, another goal which we are not finding it easy to achieve. So poor statin adherence, I will not go into the causes of this, why that happens. Even with PCSK9 inhibitors, the LDL-C variability is well established. Inclisiran has the potential to improve this compliance, and that is probably the most important aspect of inclisiran, because it's once you start, first dose 0, second dose 3 months, and then every 6 months, only 2 doses a year, improves the patient compliance or improves the patient adherence like anything. And this, from very small experience, we have seen that. And it demonstrates significant sustained LDL lowering. If you compare it with evolocumab, maybe little less LDL lowering, but in terms of compliance, it wins. That brings me back to this concept of sustained and long LDL lowering. This has come from a meta-analysis from William Horton et al., which was published 2 years back. And the concept is that how many years of life, every year, what kind of cholesterol exposure has been there. So you take an average of cholesterol exposure. So your cholesterol exposure, if you measure it 4 times or 6 times in a year, and it is averaging around 130, then your cholesterol exposure for that year is 130. If you count like that from year 0, what happens when a child is born, or when neonate, LDL levels are around 40, 50. And then it goes up in teenage, usually it goes up to 120, 130, which we normally see. And then it creeps up by the age 30 or 40. And typically, you get first heart attack at 70. This is normal. At somebody getting a heart attack at 70, we say, okay, that's fine. That's how life goes, and 70 is okay. So that's normal. Based on meta-analysis of so many studies, they proposed that it's a simplified formula, but total 7 grams of exposure to LDL-C brings an event. Lifetime exposure to 7,000 milligrams of cholesterol brings an event. So if your LDL exposure is average 100 milligram per year, starting you were at 50, then 60, then 100, 130, average is out at 100, then you will get your first heart attack at 70. And that's normal, and that's how most of the populations go or used to go. If LDL level is averaging 200 milligram per year, the same first heart attack will come at age 35. And what is the proof? FH. Familial hypercholesterolemia patients who have from birth LDL levels in vicinity of 200. And typically, they get MACE or first heart attacks in their 30s. So the argument from this meta-analysis, of course it's simplified, but the argument Braunwald made in that particular talk was that if you average somehow LDL 70, I would get my first heart attack at 100. So title of his talk was How to Get Your First Heart Attack at 100. Very interesting. I agree that it is slightly simplified, but at the same time, there are lots of pointers and indicators that this is true. If you bring down the LDL level at 40 in your patient who is 60-year-old and has had significant triple vessel disease, meaning thereby he's already exposed to 7 grams of LDL-C. At 40 milligram average per year, it is going to take almost 25 years for him to get 1 gram more exposure. So if you detect them early and bring the LDL level down to 40, probably you will save a heart attack for next 10, 15 or 20 years in these patients. And this is the diagram from Horton et al. That red line is FH patients. By age 35, they get clinically apparent ASCVD. That orange dotted line is at 7 grams. If you catch them at 35 or 30 and you see that they have been exposed, for primary prevention, anyone who has been already exposed to roughly 3 grams, and you give inclisiran or some such agents, forget inclisiran from this graph, but any such agent, and skew that graph down, bring down his LDL level to maybe 50, 60 or 70 or 50, and then so that it averages out at 70 per year, then first heart attack at 100. Very interesting and thought-provoking calculation. Anyway, I'll end my talk here. Cumulative exposure to LDL-C increases the risk of ASCVD. That's key takeaway number 1. 1 in 10 patients report a second event within the first 100 days after experiencing an MI or ACS. Early and sustained non-HDL-C or LDL-C lowering results into the lowest risk of CV outcomes. Adherence and LDL-C variabilities are major challenges to achieve sustained reduction, and not only inclisiran, anything. In fact, efforts are underway now to develop a vaccine, and inclisiran is like a vaccine. If you can, forget everything else, if you can develop a medicine with no side effects, which can be given once a year or maybe once in 5 years, which is not very costly, Sion hospital patients can afford, would it really reduce the MACE by 70 or 80%? In that case, it would be competing with lifestyle. Thank you.
Thank you so much, sir. Comments from the experts or chairpersons?
Sir, where will you put inflammation as one of the major risk? Inflammation is one of the major risk contributor apart from LDL.
Absolutely. It's a very intriguing question. Number 1, inflammation is a very important precipitating factor. as far as inflammation is concerned, right now all the data points to it being a major precipitating factor. People who live close to highways, people who are more exposed to traffic pollution or air pollution, people who are exposed to water pollution, they all sustain higher amounts of events, higher number of events compared to those people who have the same risk factors otherwise and are not exposed to those inflammatory factors. Now, what about inflammation causing vascular narrowing or atherosclerosis? I probably would say that people like W.C. Roberts or any big pathologists would term it not as atherosclerosis, but for the better want of term, you will have to say something like that. But inflammation causes vessel narrowing, that is a fact. So probably the only other factor which works by some other mechanism other than driving LDL into the vessel wall, driving vascular narrowing in some ways other than LDL oxidation is inflammation.
Lipid abnormalities.
Right now, all the associations recommend cholesterol screening at age 20. First screening at 20. If you have evidence to believe, or if you have more risk factors in a given individual, you can check it early. But by and large, for general population, first screening at age 20, and then 30 onwards, you start screening regularly.
Regularly means in a year, how many times?
Every year.
Yearly.
Yearly.
And when to treat without risk factors? At which age?
If you don't have any risk factor and LDL levels of 160 at age anything above 20, I would be inclined to treat that. But I would search for other risk factors first, and I would still give lifestyle changes a first preference. And by treating, I mean lifestyle changes is a treatment.
Because the model you have projected is something which is...
Yeah, if that is true, then it's like iodizing the salt. It doesn't prevent, it doesn't take away the thyroid disease, but it helps.
Samir, I had read somewhere long time ago that, human beings, if free of disease, and this is from Caucasian mountain, the apoptosis, which will eventually kill you, of natural is 180 years is human life. Now, for that 180 years, is there any science that what should be the LDL cholesterol? The reason I'm asking is the memory molecule is cholesterol, the major memory molecule. In all our cerebral cortex 6 layers, the richest molecule is cholesterol. It remains inert for 30 years. So if you are talking of reducing it to how much, and are you sure it will not affect the brain?
Yeah, so if you say that like hunter-gatherers, where from their remnants and from their whatever skeletons, whatever is available, what we have found is that they had LDL levels of 50 in those days. So if you go by this theory, 7 gram exposure with 40 or 50 milligram exposure every year average, that would probably go to 100 and just do the math, 5 grams at 100 years or 4 grams at 100 years. So by 180, you will get 7 grams. So that is fine. Now the problem is that that is natural. You have 40 or 50 milligram naturally. And now you are adding medicines to suppress it. Is there any difference? That is something we don't know. And we in medicine, we know that someone who naturally has arrhythmia-free ELR and someone who has arrhythmia and you give him medicine and make it arrhythmia-free, is there any difference? Yes. So inherently, somebody is now built to have that kind. So it's exactly like people who say drink red wine, or people who are carefree. So do they get their health benefits from drinking red wine, or because of their nature, which is gregarious, which is more sociable, which is more happy, kind of? So what comes first? We do not know. So we need to look into this at a great depth. But what I mean to say is this is very thought-provoking. When Braunwald gave this talk in 24, in fact, January 24, it was very, very insightful.
Yeah, Yash, but the human brain and other organs, even including adrenals and kidneys, they manufacture their own cholesterol locally. These organs are really not dependent on circulating levels of cholesterol. That is number one. Second thing is, we all know that our umbilical cord level of LDL is 30 mg/%. So you are sent on this planet with a LDL level of 30. Then XYZ happened, McDonald's happened, and Kentucky Chicken happened, and everything happened. And then you got the LDL of 160. So then, as he said, if you maintain your LDL levels of 50 from the age of 20, you will get your ASCVD threshold at the age of maybe 80, 85, if not 100. So I think that the point you've taken is very, very valid. But this is the logic that, and majority of the PCSK9 trials, even after the trial has ended, they have followed up patients. And there was no real cognition impairment or dementia and all that. And even if they happened, the placebo arm had a similar incidence. In fact, in the aliricumab trial, the placebo arm had a higher incidence of dementia than the treated arm. So I don't think that that's a real.
And with the concerns with statin of cancer, of high sugar levels, of intracerebral hemorrhage or intracranial hemorrhage, and the violent behavior. All these things, most of them are found not to be consistent across the studies. And the other thing is that if you talk about all-cause mortality, finally, that wins. So maybe there is slight increase in the sugar levels, but you are getting to live a longer life and a better life.
It's not because of the use of statins, which will produce that is why ezetimibe has a role. So it's better to use ezetimibe with statin rather than statin.
Yes, you're right, probably, and for several reasons. And another reason is that the combination therapy gets you to the goal more quickly and with less effort and with less side effects. So that's why we are talking more and more about combination therapy right now. I would still take LDL variability with a pinch of salt, because LDL variability can happen because of so many reasons. The patient may be forgetting to take the statin. Patient's lifestyle as he grows older may be becoming more inactive, or maybe stress levels are changing. So many other factors which we have not accounted for LDL variability. So I think we need many more studies on that.
I think with the paucity of time, we
Thank
might
you.
have to conclude the
Thank
session.
you very much, Dr. Samir Dani. And I request Dr. Unadkat to felicitate Dr. Samir Dani, and Dr. Tarun Madan. Is going to felicitate all the chairpersons, and Dr. Sanjeev, please felicitate all experts.